all of you are able to go through our sessions well and getting the feedback as well. So I'm glad that all of you are able to appreciate what is the knowledge being shared. And I'm happy that my colleague is here again with all of you for part 2 of gastrointestinal symptoms, which will specifically be about bowel obstruction. With that, over to you, Dr. Sangeetha.
Thank you, Dr. Deepak. Thank you, Sri Priya. Good to see you everyone back again. So let's move on to today's topic. Okay, gastrointestinal symptom. This is our second part where we are going to deal with bowel obstruction. And bowel obstruction, it is one among the common mismanaged symptoms or mismanaged problems when it comes to GIT. Well, I hope most of you might have seen a case of bowel obstruction. And today we are going to discuss this in great detail in a palliative care perspective. And today, things that we will be covering.
Are you communicating by any chance? Because I believe we are not getting your voice. Is it same with everyone?
Yeah, I think Sri Priya, there must be some glitch on your end. Dr. Anirban has given a thumbs up. I think we are audible. Yes, yes, we are. Dr. Jyoti also can do that. Yes.
Some mistake from my end. Please continue.
Okay, thank you.
You are audible.
Thank you, Dr. Nandini.
Thank you. Okay, so today we'll see the classification of intestinal obstruction, the symptoms associated with, and how do we come to the diagnosis of intestinal obstruction, and very importantly, the management and the treatment per se in a palliative care perspective. So before we move on, I think we'll go through a case scenario. Here we have Mrs. Mary. She's a 62-year-old woman who was diagnosed with stage 4 gastric adenocarcinoma with metastasis to peritoneum and anterior abdominal wall. She had a palliative distal gastrectomy followed by chemotherapy. Unfortunately, a repeat CT scan was taken after her 2 cycles of chemotherapy, and that showed progression of disease in peritoneum and abdominal wall. So this case scenario should be in your mind so that as we go through the further sessions, you'll get some idea of what we are going to discuss, and definitely you'll have more questions and we will address all that. So intestinal obstruction, it is as per definition, it is the restriction of the normal passage of intestinal contents. And there are 2 types of classification, non-mechanical and mechanical. In non-mechanical, it is basically paralytic ileus. It can be functional obstruction, adynamic bowel. Can someone say me what is a condition that you see adynamic bowel obstruction?
So please feel free to use the chat box or even unmute yourself.
Paralytic ileus.
Hypokalemia, yes. Dr. Purnima says hypokalemia. Excellent. So hypokalemia is a condition where you see a dynamic bowel. And in this case, there is absence of normal peristaltic contraction. And the pain here in this condition is comparatively less. And the bowel sounds will be absent in this condition. Whereas in mechanical or the dynamic obstruction, it is further classified depending upon the speed of onset, the site, the nature, and the etiology. Speed of onset, it is acute, chronic, acute on chronic, and the site, depending upon the site, we say it as a small bowel or large bowel obstruction. Depending on the nature, it can be simple, closed loop, or even a strangulated obstruction. And coming to the etiology, it can be intrinsic, extrinsic, or intraluminal. In dynamic obstruction, here the bowel is capable of contracting normally or even excessively proximal to the obstruction. That is in for example, in simple, depending upon the nature, if it is a simple obstruction, there is obstruction only at one particular point, and there is no vascular compromise happening here. Whereas in closed loop, the obstruction is happening at 2 points. It forms a loop. And there what happens is, grossly you can see the bowel will be distended in such cases. And here there is a risk for perforation, something which we can see in a sigmoid volvulus. And in strangulated, the blood supply is compromised here. And there is sharper and more consistent localized pain at that particular site. And there is peritonism, fever, increased WBC count can be seen, and there is signs of mesenteric ischemia. Okay. Now, as we said, there is dynamic and adynamic causes. In the cause, it can be intraluminal factors which is causing the obstruction. It can be intramural, which is causing the obstruction, or extramural factors which is leading to the obstruction. Intraluminal means inside the lumen there is something which is causing the obstruction. For example, it can be impaction, it can be foreign bodies, or viscera, or even gallstones. Intramural, something in the musculature. So there can be a stricture, or even it can be the malignancy itself that which is growing, causing the obstruction. In extramural, it can be a band or adhesions due to previous surgeries, or it can be hernia or volvulus or intussusception. When it comes to adynamic causes, it can be paralytic ileus or mesenteric vascular occlusion or pseudo obstructions, which is leading to mechanical obstruction. Now, a person is coming to you. The Mary, the case scenario which we discussed earlier. The speaker's video is freezing. Okay. So can someone say me what is a typical presentation of a patient who is coming to you with intestinal obstruction?
He will have acute abdominal pain.
Okay. Can you
And
describe
there will
the
be
pain?
vomiting. There will be recurrent vomiting.
Okay. Abdominal distension, yes. Vomiting. Colicky. Okay, why is this abdominal distension happening? Yeah, Dr. Ravi Shankar says there is secretions, dilated bowel loops. Inability to pass flatus, constipation. Okay. So there is some problem here.
Just excuse us for a moment. We'll just have a look at what's happening with the presentation.
Asking about, yeah, here I was asking regarding these symptoms. So many of you said, can you move to the next one? Yeah. So as many of you said, there can be colicky pain, there will be bowel distension, there can be nausea and vomiting, and there can be, the pain can be a continuous type of pain also. So here in this chart, you can see what is causing this particular symptom. So the bowel distension, it is due to the increased bowel contents, the increased gut epithelial surface area, and there can be increased bowels. This leads to increased bowel secretions. So this bowel secretions, in turn, what it does is it causes nausea and vomiting. And there is damage to the epithelium due to bowel inflammatory response, and this leads to the continuous pain. The partial or complete bowel obstruction, here typically what you can see is colicky type of pain. The bowel contraction occurs surmounting to the obstacle. there is decrease of decreased movement of the intestinal contents, and this in turn leads to bowel distension. All right. So the typical features that you see is colicky type of pain. There can be bowel distension. There can be high volume vomiting, especially in partial bowel obstruction. It can be leading to nausea and vomiting. There is continuous pain. So these are the typical signs that you see here, typical symptoms that you are seeing the patient with. So this is the cause for, or this is the reason why the patient is presenting to, this with you. Can you move to the next one? Okay. So, just move to the back, previous slide. So, how do you differentiate, like, what type or where is the obstruction? How can you say this patient is having partial bowel obstruction, or how will you investigate this patient if you are having a diagnosis of, or if you think the patient is presenting to you with the intestinal obstruction? What is your further management?
Standing X-ray abdomen.
Okay. What else?
Which shows the air fluid levels.
Okay.
A gas under diaphragm if there is perforation.
Okay. What else?
Then even clinically you can percuss and palpate and see, then you will get some clue. Even if you do clinical examination of per abdomen, you will come to know.
Tense abdomen.
What else? What if the patient is in home care? You're seeing the patient at home care.
You can ask for portable X-ray, portable USG. Now USG is available on laptop also. So you can ask for portable USG.
Okay. What if you don't have any other facilities, something like that, or you don't have a X-ray, you don't have facility for doing USG? You are seeing the patient at a rural area.
So you can palpate and see if the patient has on percussion, you will know whether there is a fluid. And you can palpate and see where is the tenderness. If it is a...
Okay. So, yeah, what all you are saying is right. But
you can also take abdominal girth by measuring tape.
Okay.
Guarding rigidity.
Okay. Yes, ma'am. Thank you for that response. So here, the patient is presenting to you with all the symptoms, and you're seeing the patient in a rural area, and the patient is saying, I'm having severe pain, I'm vomiting in large volume. The entire bucket, he'll show you the entire bucket filled with vomitus. See, I'm having this much of vomiting since yesterday. And not able to pass motion or flatus. So what does that indicate? Yes, history taking. The history itself will say you where the obstruction is. Okay, so if the patient is having high volume vomitus, severe pain, not passing flatus, or not able to, is having constipation, it indicates that it is a higher level obstruction. So if the patient is having severe abdominal distension and there is no bowel sounds that you can hear, what does that indicate? Most probably it can be a large bowel obstruction that is happening there. Shripriya, you can move on to the next slide. Okay, so the level of obstruction determines the pattern of symptoms. Higher the level of obstruction, the person will be having the vomiting develops early and in large volume. If there is obstruction at the large bowel, it can be progressive and abdominal distension is more. In complete obstruction, what you can see is there is no passing of flatus or no feces, and even the patient can present with spurious diarrhea. What is spurious diarrhea? Any volunteers? In last class, we have discussed in detail regarding spurious diarrhea.
Yeah, you told about it. It is that motion coming from the side of the stools and causing as if it is a loose motion, whereas the volume is getting accumulated above the impacted feces.
Yes, sir. Thank you. So that is an indication that the patient is having chronic constipation. And that could be the reason for the intestinal obstruction. All right. So here what you have to remember is the higher level of obstruction, the patient can present to you with increased in volume of vomiting, and the patient will be vomiting in large volume, and the vomiting develops in an early stage. Large bowel obstruction, it can be progressive, the abdominal distension is more, and in complete obstruction, there is no passing of flatus or feces, or even the patient can present to you with a spurious diarrhea. Sripriya, next slide. So here, as many of you said, even X-rays can help you here. If you are able to take an X-ray, you can see there is multiple air fluid levels. Even you can do a contrast radiography if it is available with gastrogryphon. Next slide. Yeah, this is an X-ray which was taken in supine position. And also the next one, you can see it was taken in erect position, where you can definitely see the air fluid levels. Okay, next slide. Now, how are you planning to do the management in this case? The patient is having severe pain, vomiting. What antiemetic are you planning to give? Or what are the management options that you are aware of?
IV and ondansetron, and if I will put an RT.
Okay. What else? The patient is crying in front of you with severe pain. Yeah, Dr. Jyoti is saying nil per oral pain management. Yes.
Then IV Metrogil and one higher antibiotic.
Okay. What else? IV fluids. Yes. Opioid analgesia, steroids. Okay. What steroid are you planning to give, Dr. Jyoti? PR examination, glycopyrrolate to decrease the secretion. Dexamethasone. Okay. Why did you choose dexamethasone?
Because it is anti-inflammatory. It has anti-inflammatory action.
Okay. What else? Why did we choose dexamethasone specific? Why can't we choose any other steroids?
It also decreases the edema.
Okay. It is long acting. Yes. In incomplete bowel obstruction, opioids and metoclopramide. Do you want to say more about it, Dr. Hina?
In case of incomplete obstruction, we can give a prokinetic that will increase the motility. But if we are suspecting complete bowel obstruction, Then we can give opioids in case of incomplete, but in case of complete bowel obstruction, we cannot give these won't help opioids.
Case of complete obstruction, you don't use opioids.
Yes.
Okay. Okay. How is there any other management that you can do in intestinal obstruction? You said NPO, antiemetic, steroids, opioids. Okay. Other than medical management, is there any surgical options available? May need surgical intervention. Okay. What do we do in surgical intervention? Any surgeons in the group? Depending on the level, ileostomy or colostomy. Okay. Exploratory laparotomy, depending upon the etiology. Okay. Okay. So here, as everybody said, there are different options. It can be conservative, medical management, or it can be surgical. So how do we choose the person should be going for medical management, or how do we choose the person should be going for surgical management? So that is what we are going to see here. Next slide. So when the patient is presenting with symptoms of bowel obstruction, first of all, what we do is we do the clinical assessment. We see what type of vomiters he's having. You do the full physical examination part, all examination you do, and then you understood, okay, here this person is having small bowel obstruction. And then if there is options for doing radiological assessment investigation, you go ahead with that. Okay. Now next thing is you're planning for surgical management. Okay. So when it comes to surgery, whether the patient should be doing the surgical intervention or not, definitely there are particular criteria. And in that, patient factor is the important thing that you have to consider. What is the performance status? In this chart that you see here, the age is written first. But as we all know, age is just numbers. So check for his performance status. That is what I would go for. Even if he's 70 years old, if his performance status is good, if he's able to tolerate that, okay, we can try. After discussing with the family, if they want to go for that, okay, we can try that. If his performance status is good, we go with that. And then you have the stage of cancer. At what stage the patient is presenting with intestinal obstruction, the stage of cancer that you have to see. The future anti-cancer treatment options that is available, or what are they planning to do for this patient in this stage? Is there any malnutrition, or is there any cachexia or concurrent illnesses? So these are the patient factors that you have to keep in mind. Okay, first of all, the performance status, the age of that person, the stage of the cancer where he is, the future anti-cancer treatments that this person is going to go through. Is the patient malnourished or cachexic, or there is concurrent illness for this person or not? So these are the patient factors that you have to keep in mind before going for a surgery. And the disease factors, the extent of obstruction. That is it a single level obstruction or a multiple level of obstruction that is there? So how far you can resect? If it is a single level, okay, maybe you can resect. If the patient is okay, his performance status is okay, you can go ahead with the surgery. If there is multiple level of obstruction, there is no point in doing resection, isn't it? Then the site, is it proximal or distal? The etiology, the functional and functional versus the mechanical factors which is causing the obstruction. Is there ascites in the patient, for the patient? Or is there carcinomatosis peritonium? So these are the disease factors which you should keep in mind before planning or while making decision in case of intestinal obstruction for that patient. There are technical factors, the degree of invasiveness, interventional radiology, endoscopy, laparotomy or laparoscopy, anesthetic requirements. These are all other technical factors when it comes to coming to a intervention in surgical interventions. All right. So when a patient is presenting with these symptoms, do the clinical assessment. If there is an option for doing radiological assessment, go ahead with it. And when you're planning for surgery, see the patient factors and disease factors. Where is your patient? If he is able to tolerate that, only then go ahead with surgery. Otherwise, don't disturb the patient. All right. Next slide. Okay. So this is just a summary of the previous one where it is a complete no for surgery. Okay. So poor surgical prognosis. If you expect the patient is going to have poor surgical prognosis, this is a candidate for conservative management. Okay. For example, in case of advanced age with cachexia, that is definitely a no for surgery. Widespread tumor or deranged metabolic parameters, definitely no for surgery. If the patient is having ascites, low serum albumin, severe nutritional deficiency, there is palpable abdominal mass or previous radiotherapy to abdomen or pelvis, definitely a no for surgery. History of combination chemotherapy, multiple sites of obstruction, poor peristalsis due to diffuse carcinomatosis peritoneae, and poor performance status is definitely a no for surgical intervention. All right, so this person with these features is a candidate for conservative management. And there is definitely a lot of ways through which you can manage these person's symptoms. This not just the surgery. Okay, here in detail, we'll learn how we are going to do the conservative management for this patient. Okay. Sripriya, next slide. Okay. So we are going to treat this patient now. We are going to conservatively treat this patient now. And for that, pharmacological, surgical, and invasive procedures. I have categorized into 3. When it comes to pharmacological management, first and foremost, you have laxatives. What type of laxatives do you prefer to give this person? The person is having intestinal obstruction. What laxatives are you planning to give? Is it bulk forming, stimulant laxative, or is it stool softeners? What do you prefer?
Stimulant.
Okay. Why did you choose that?
Because it is not the bulk is not the problem in that. It is a stimulant. It will be useful for them to evacuate. The secretions are there, so a stimulant will be more helpful to evacuate.
Okay.
Ma'am, in case of a total obstruction, is it safe to give a laxative, stimulant laxative?
Excellent, excellent. I was about to say that. In case of complete obstruction, if we use a stimulant laxative, it can worsen the pain. If it is a partial, if it is a partial intestinal obstruction, definitely you can go with
See, we'll give laxative only when there is a partial obstruction. A complete obstruction, obviously, everybody will avoid a laxative to be given.
Okay. Yes. So we prefer in partial obstruction, we prefer giving stimulant laxatives along with stool softeners. So that can be used. And we also give enema. We do a rectal examination and we see if there is any fecal matter or fecal, whatever, if we can feel that, we try to do a digital evacuation. If not, we put we do a high-up enema. As I said in the previous class, we put a suction catheter, we give the phosphate enema, and we try to evacuate. Maybe in one day, if you have given enema, it may not work on that day itself. Maybe you will have to repeat the enema on the next day, depending upon the patient's condition. Okay, so definitely stool softeners, bisacodyl or the stimulant laxative, if it is a partial obstruction, you can try. And enema is our other option. Now, next we have corticosteroids. And as many of you said, dexamethasone is a corticosteroid which we prefer. Especially we use it starting from 16 milligrams is the usual dose which we start. But I have seen my seniors using it or starting the dose from 24 depending upon the case, if it is a very severe obstruction. So yeah, 16 milligrams, we give it as a OD dose. We prefer giving it before 3 p.m. And why do we prefer giving it? Anyone?
Causes sleeplessness.
Yeah, it causes some sleep disturbances if we give it in the later part of the day. So we prefer giving it as a OD dose, preferably before 3 p.m. Okay. And it has a very good, anti-emetic property as well. And coming to anti-emetics, what is the preferred anti-emetic in this condition? Will you give metoclopramide?
In
With
partial
incomplete
obstruction, yes.
obstruction, we can give metoclopramide if it is partial obstruction.
Okay. What happens when you give it in complete obstruction?
That can worsen the obstruction
How?
because not help because of the obs complete obstruction. So prokinetic will not help in increasing the cut motility.
Yes, yes. So here metoclopramide is a prokinetic. It causes peristalsis. So when there is complete obstruction and you give metoclopramide, it is going to have an opposite action. It causes severe pain for the patient and the patient will have a lot of distress. Isn't it? So we have to see if the patient is in partial bowel obstruction, only then we give metoclopramide. And if the patient is, once you start, you can give a trial of metoclopramide and see if the patient is in partial obstruction, you give metoclopramide and see how the patient is responding. Once the patient is started showing signs of pain or you are not able to get bowel sounds on auscultation and you feel that it is going into a complete obstruction, you stop metoclopramide and then you can change it to maybe ondansetron, or even you can add buscopan, which is your hyoscine butyl bromide. It is anti-secretory. It also helps in decreasing the secretion and thereby nausea and vomiting. So you can add haloperidol as well. It is also an anti-emetic. Okay. So see what your patient is. You have to closely monitor the patient and use your medications accordingly. And then you have your somatostatin analogs, which is your octreotide. It is mostly not used in our scenario or here in this part in our institution. It is a little bit costly also. And instead of that, what we prefer using is buscopan. It is also having similar actions. And analgesics, definitely we prefer giving opioids, even though it can cause constipation. Here, we want the patient to be pain-free. We have other methods to manage his constipation. So we prefer using opioids here. Okay. So pharmacology management, you have your laxative, corticosteroids, antiemetics, anticholinergics, somatostatin analogs, analgesics. Is it clear? Now we have surgical treatment. As you said, there is you can do the resection of the bowel segment, colectomy, ileostomy, or colostomy. Ileostomy is quite difficult for the patient. Even colostomy is difficult. In ileostomy, it is more, the volume of feces will be more. Okay, now invasive procedures, as one of you said, you can put a NG tube or you can do a gastrostomy or colonic stents. So in NG tube insertion, definitely it is a bit difficult for the patient. Always ask for the patient's consent. Only then you insert your NG tube. Okay. As we said, the vomiting is very maybe in high volume in small bowel obstruction. It can be bilious vomiting, or even sometimes if it is a large bowel obstruction, sometimes the patient may have fecal vomitus. So it is very difficult for the patient as well as the family to see and be in that situation, isn't it? At that time, NG tube insertion will benefit the patient, and you can connect the NG tube to the bag where the secretions can be collected in the bag. Next slide. Okay. Now, here in detail, we are looking, we'll learn about the antiemetics used. Metoclopramide, dopamine agonist. We give it at a starting dose of 10 milligrams 8 hourly. You can give it as sub-Q, and then gradually increase the dose on a day-by-day basis. In higher doses, it can go from 30 to maybe 120 milligrams over 24 hours via subcutaneous infusion. So in this condition, mostly it is very difficult to get a IV line, and also in home care setting, it is easy for us to put a sub-Q and start these medications. Okay. Then 5-HT3 antagonist and prokinetic only in partial obstruction. The dose, as we said, it can be 40 to 120 milligrams per day over sub-Q. Haloperidol can be given in case of nausea and vomiting. These are the common antiemetics which we use: metoclopramide and haloperidol. Next slide. Then we have corticosteroids. Usually what we prefer is dexamethasone. We can start at a dose of 16 milligrams per day. It is a long-acting steroid, and it should be given before 3 p.m. and a late administration can interfere with the patient's sleep. So it should be given for 5 days and slowly taper it down. It's not like one day you give and then you stop. No, you can't do that. So you give it for 5 days and slowly taper it down. If you're giving 16, slowly taper it down. And if vomiting subsides, you can continue. You can change the IV to oral steroids. Then steroids act by reducing the peritumoral edema. This is very important. What steroid does is, you have an obstruction. It can be the tumor obstructing the lumen. And what this steroid does is, it decreases the edema around this tumor, and there will be some space now. So that's how it decreases the peritumoral edema. So here you have to monitor the blood sugar levels of this patient. Of course, steroids can increase the blood sugar. So monitor the patient's blood sugar and adjust it with your insulin if required. Next slide. So next, again, we have somatostatin analogs, octreotide. It has a starting dose of 100 to 600 micrograms per day, and it will reduce the secretion and slow down the motility and reduce the splanchnic flow. It increases the absorption of water and electrolytes. It is potent anti-vasoactive intestinal peptide effect. Also tried as a preventive step. It is available in depot preparations like 20 milligrams for 4 weeks. It can be used along with steroids. Next. So this is how your prescription will look like. You have your dexamethasone, 8 to 16 milligrams subcutaneously. You can give over a period of 3 to 5 days and slowly taper it down. And you have your metoclopramide, which is 30 to 120 milligrams over 24 hours subcutaneous infusion. We don't give metoclopramide and hyoscine butyl bromide together because it has opposite actions. So if it is a partial obstruction, you can go ahead with metoclopramide. If you feel it is a complete obstruction, you have to choose Buscopan. All right. And the other antiemetic that you can use here is haloperidol. Definitely, there is no one drug or one antiemetic that you can use. You need to use maybe a combination of 2 or more in controlling the vomiting. Okay, so you can use haloperidol also in addition to your metoclopramide. And then you can use ranitidine in case of, ranitidine is also given with a starting, 24 hours of 300 milligrams per day. So that is a usual dose. So when you are seeing the patient or when you're treating the patient with intestinal obstruction, make sure these things are there in your drug chart. Next slide. So these are the common questions which you are going to face from the caregivers. The caregiver will come to you saying, oh my God, this you have kept the patient on NPO. I can't see my mother lying down like this. She hasn't eaten anything. She's not able to drink anything. She's feeling thirsty. Or even the patient himself will be saying you, I'm feeling hungry. I need to have something. Please do something. What will you say to them? It is definitely a difficult situation. Hydration is important, and you can give IV fluids. But when you are giving IV fluids, you should be very careful, because overhydrating can also be a problem. Because when you overhydrate, it in turn can increase the secretions and thereby leading to vomiting. So make sure you monitor the patient. After you are giving IV fluids, see how the patient is responding to it and give IV fluids accordingly. Okay. Now, most probably you're starting him on the patient is on NPO. Sometimes you can ask him to take sips of fluid. He's feeling thirsty. Why is he feeling thirsty? The patient is continuously vomiting. Definitely his oral cavity, the oral care will be very poor. He may be having oral thrush or candidiasis. Check if he's having anything like that. All this thing can cause increased dryness. So oral care should be advised. And how do you give oral care? Any volunteers?
Ask the patient to gargle. And patient is if the patient is of obstruction, we usually keep nil by mouth.
Okay. What if the patient is having a very poor prognosis? Still, do you want to keep him on NPO? The patient may be having maybe few days in front of him. He's saying, she's asking you, I'm feeling hungry. What will you do? See, it is very difficult, isn't it? Sometimes it is difficult, and you may have to say the patient, it is okay to have oral sips, even though the patient is on Riles tube. Okay, even though the patient is on Riles tube, if he wants, he can take sips of fluid. If he's able to tolerate, it is okay to take sips of fluid. Yeah, in the chat we have candid mouth pain. Yes, we can give oral cavity care, oral care with local.
No, but if the patient does not have any antifungal candidiasis, why candid mouth pain? We don't give just for preventive candid pain.
No. If he's having oral thrush, or you feel it is candidiasis, you can give oral candid mouth pain. Otherwise, you can do oral care with the saline preparation. In the last class, I have said you, in a glass of water, you can put a pinch of salt or soda bicarbonate, and with that water, you can do the gargling. That is enough. And in between, you can ask him to take sips of fluid. It is okay. Even if the patient is on on Riles tube, you can ask them to try in a sitting position, ask if he wants to take sips of fluid, he can take it, and just observe him. Okay. Now, coming to TPN, depending upon the patient's prognosis, you can use TPN, total parental nutrition. Next slide. Total parenteral nutrition is justified in patients with minimal tumor burden. Okay, and candidates for definitive surgery and in patients with good performance scale. Only then you can, only then the patient can have total parenteral nutrition. If the patient is having a good prognosis and the candidate is a person is for a definitive surgery, if he's having a good performance scale, then you can go ahead with total parenteral nutrition. And also you feel the patient is having good life expectancy, then you can suggest the patient to have total parenteral nutrition. And the thing is, it is a little bit costly also. If the family is able to afford, definitely you can suggest this. So next slide. So here we come back to this case where 62-year-old Mary, she's a 62-year-old woman, Mary, she's supported by her children living in UK. She was diagnosed with stage 4 gastric adenocarcinoma with metastasis to peritoneum and anterior abdominal wall. She had a palliative distal gastrectomy followed by chemotherapy. Unfortunately, a repeat CT showed that repeat CT was taken after 2 cycles of chemotherapy and showed progression of the disease and in disease in peritoneum and abdominal wall. So here she is having stage 4 gastric carcinoma and she is having a poor prognosis. There is metastasis to peritoneum and abdominal wall. Okay, next slide. And she's presenting with vomiting and abdominal colic for 2 days, but was still able to pass small amount of stool daily. She had vomiting 3 to 4 episodes per day, which was unrelated to her meals. Vomiting was bilious with partially digested food. And on examination, she was not dehydrated. Her abdomen was distended. The bowel sounds were sluggish. There were palpable nodules on the abdominal wall and it was tender. So in this condition, what do you think is her diagnosis? She's having vomiting. It is a bilious vomiting. She's able to pass small amount of motion. The abdomen is distended. You can hear her bowel sounds.
Partial obstruction.
Yes.
In perforation, we will not hear bowel sounds.
Yes. So here she's presenting with partial bowel obstruction. What is the indicators? How did you understand it is partial obstruction?
Because she is passing some amount of stool.
Okay, what else?
And there is bowel sounds are present.
Okay. Now, how do you think? Okay, next slide. So in view of persistent vomiting, a nasogastric tube was inserted. Mary was told that the nasogastric tube insertion would be a temporary measure for decompression. So definitely she was not happy with that. That is why she would have asked, why is this nasogastric tube? And they had to give an explanation saying that it is for decompression, isn't it? So next the CT scan was taken and it showed a small bowel obstruction with a transition point at proximal jejunum. So as you said, it is a small bowel obstruction. It was confirmed with a CT. Now, as she was still opening her bowel, the impression was partial rather than complete obstruction. And the intention of management was to reverse the obstruction. Next slide. So this was her treatment. This is her drug chart that you can see here. She was given bisacodyl suppository And IV metoclopramide was given 10 milligrams every 8 hours. And intravenous dexamethasone was also given. And she was also started on fentanyl infusion, 10 milligrams, 10 micrograms per hour for worsening of nociceptive lower abdominal pain from the peritoneal metastasis that had been present for 2 months. So when you see this prescription, what do you think? Is it sufficient? There is bisacodyl suppository, IV metoclopramide, intravenous dexamethasone. Is this sufficient? Or do you want to correct this?
You can add IV fluids.
Okay. What else?
You can add antacid like ondansetron or Rentec.
Okay. She was given bisacodyl suppository. Do you think it is going to help her?
It will help whatever is she might pass the stools. Whatever is the collection.
She's having partial bowel obstruction. Bisacodyl suppository, is it really going to help her? I don't think it is going to help her. We have to definitely do a PR and see what is the condition and then manage accordingly. She needs some amount of stool softness and definitely an enema may help her. And next thing that you see is metoclopramide. Do you think the dose is sufficient? The dose is not sufficient. You may have to increase the dose of metoclopramide here. And also the next thing is written dexamethasone intravenously. You have to give 8 milligrams per day. Do you think that is sufficient?
It has to be 16 milligram per day.
Yes. So we have to start dexamethasone 16 milligrams per day if you think the
And
patient
it has to be given after 3 p.m.
before 3 p.m.
Okay, sorry, before 3 p.m.
Yeah. So dexamethasone dose is not sufficient here. Definitely metoclopramide dose is also not sufficient. And fentanyl infusion was started for her pain. Next slide. So now what happened? There is no bowel action. The intravenous metoclopramide was increased to 60 milligrams per day on the following day. And there is marked clinical improvement after 2 days later. And the NG aspirate has reduced significantly. And she had no more vomiting. The team of doctors were able to remove her nasogastric tube and started her on oral feed gradually. Intravenous metoclopramide and dexamethasone were continued for 2 days and stopped subsequently. 3 days later, she started vomiting again. She had 3 episodes of vomiting in a day, which contains moderate to large amount of bilious vomiting. She was recommended on intravenous metoclopramide 60 milligrams per day and dexamethasone 8 milligram per day. In addition, IV ranitidine was added to reduce the gut secretion. Despite all the treatment, Mary's symptoms persisted. Now, what do you think happened here? We said in the previous slide, her dose was not sufficient. The metoclopramide which we gave her, it was not sufficient. So the next day, what they did, they increased the dose of metoclopramide. After increasing the dose of metoclopramide, what happened? She had good improvement, and following which they were able to remove her nasogastric tube, isn't it? Now, suddenly, what they did was they subsequently removed or stopped all the medications within 2 days. That was a problem here. I said you have to taper it down. You can't stop abruptly. When the patient is okay, you feel it is okay. When you stop it suddenly, the symptoms will come back. So here what happened was they stopped intravenous metoclopramide and dexamethasone. They continued it for 2 days and stopped abruptly. So what happened? Again, her symptoms came back and she had to suffer. Next slide. So the goal of care was established after discussing with the patient and her family. She preferred to keep the NG tube for decompression while she enjoyed taking her oral fluids. Decision was also made to stop further chemotherapy and for comfort care. She returned to home with home hospice support. So after all the sufferings, she had to go through a lot of things. At last, they decided to do the goal of care. When do you think the goal of care should have been planned or that family conference should have happened? In her condition, it was done at the last moment. Actually, this should have happened at the time of starting chemo, or maybe at the time where they did that CT scan and found to have that the condition was progressing, isn't it? So the goal of care, the planning should be done at a much earlier stage, and so that, yeah, before chemotherapy, yes, definitely. So that she would have not gone through a lot of trauma. Understood? So it is very important to identify the patient, at what stage the patient is. And once you identify the patient is having intestinal obstruction, try to make a decision with your multidisciplinary team. It is not you palliative care physician alone. It is a combined, decision making. Understand the patient where he or she is, and then try to come to a final decision which is in favor of the patient. The family will be in distress. Maybe they not be able to, they want to do everything. In this case, I said you the patient's family, the children are in UK. They could have done all sorts of investigation, all sorts of surgery, everything could have been done, isn't it? But is that really required? The patient autonomy. Ask the patient what she needs. Here it was done at the very last moment. So when you're practicing, try to understand the patient, see what he or she needs, and plan your management accordingly. This is very important. Next slide. So now we know the classification of intestinal obstruction, the symptoms with which the patient is presenting to you with, and how do you come to a diagnosis of intestinal obstruction, and the ways in which you're going to manage, and the treatment that you're going to do in a palliative care perspective. It is not just the surgery that is available for intestinal obstruction. You can also conservatively manage the patient when you're having or when the patient is presenting with intestinal obstruction. And how do you make that decision? That was clearly mentioned depending upon the patient factors and the disease factor. If the patient's performance status is good, is having good, if you think the outcome of the surgery is better, and if the patient is agreeing for that, only then go ahead with the surgical option. Okay. Next. Yeah, with that, we come to the end of our presentation.
Actually, what happens is most of the time the patient is taken care of by the caretakers for a very, very long time, like 6 months, 3 months, 1 year. So what should be the intelligent level of the caretaker for to see a patient?
Could you be more specific?
See, the patients are looked after by caretakers. Okay.
Yeah.
So caretaker should necessarily not be for 24 hours a sister or a doctor.
Yes.
Okay, so there are, according to the all over region of India, there are some caretakers. So caretaker is a very broad term. So I want you to specifically tell, in a palliative care, most of the time the patients are taken by caretakers, taken care by caretakers even at home for 24 hours. Because most of the time their relatives are abroad, they are working. So I want to know what is the intelligent level of the caretaker who can take the care of the patient for such a long time. And they are like 12 hours duty, 8 hours duty.
So I think, ma'am, what you want to ask is how much can an untrained person, right? Can an
Should be
untrained
relied
person,
on. See, the medicines are in English. So who's giving the medicine? What is the ml of urine? What is vomiting? This all we know. We know what is vomiting. We know what is temperature. But the patients are with caretakers. See, there is not a qualified sister who will stay for 24 hours with the patient. There is not a doctor who's going to stay with the patient for 24 hours. Doctor will come and go. Sister will come and go. So most of the time you are presenting, everybody is telling caretaker, caretaker, caretaker. So what is the intelligent level? There should be some standardization, no, of the caretaker. Because in palliative care, most of the time the patient is with caretaker because it's a very chronic disease.
yes, ma'am, we got the point. So I think I'll just rephrase the question to, if suppose there is an untrained caregiver, how can we orient them to take care of a person at their home care setting?
Yeah, here, as ma'am said, what the caregiver wants is comfort for the patient. So first we have to try to understand what the caregiver or what the family is understanding in this present situation. So when we say it is intestinal obstruction, they may not understand what intestinal obstruction is. You may have to go to their level and make them understand what this present condition is and say what are the possible complications that can come along with this. And if they are willing for hospital admission, we bring them to our setting and then give them the management that is possible. Sometimes if it is an elderly person, we say to the, or we make the caregiver, or we try to make the, try to understand, make, what is it? Try to we try to educate the caregiver that this may go the other way, or what are the possible outcomes of the surgery, and what all ways the caregiver can help the patient in such situation. Okay, so caregiver wants the best for the patient. So what are
caregiver
the,
can be anybody. Caregiver can be relative. Caregiver can be anybody.
Yes, ma'am.
Yes,
So
yes.
exactly the point is that as doctors, usually what we practice is, if suppose a patient,
इंडिया जो एम्स है वही वाला ऑल इंडिया एम्स
okay,
वाला है भाई
so sorry about that. So what we are saying is, usually when a patient and a caregiver comes to our OP, once in our usual practice, once we prescribe the medication, what happens beyond the four walls of our OP or an operation theater, we have never been bothered about. Or even if we have been bothered about, we have not been able to do anything about it, right? This is the usual situation which we find ourselves in. Now, what are we trying to inculcate here through palliative medicine? What we are learning is just this one thing, that we have to understand at what is the level of understanding that the patient and the caregiver are in. We are not worried about whether they are educated or not educated. Even if they are people who may not be educated or literate to understand technical jargon, which we usually tend to use. Can we understand where they stand and make it simple enough for them to understand? This is one exercise which we have to start doing. It is time consuming, yes. Initial 1, 2, or 3 settings, it is time consuming because we have to understand what have they understood regarding the diagnosis, regarding the prognosis, regarding the treatment options. All these things we have to understand from them, that where they stand. And once we understand where they stand, it doesn't matter that how much they are able to exactly understand the true nature of what the disease process is or the treatment process is. But from that point on, we can start making things simpler for them, handhold them, and ensure that we go with them step by step taking them forward. That see, we understand that this is what was communicated to you. However, there is a risk of something negative happening. What is that negative things which we need to be aware of? Even if you go home, there is a vomiting can happen. The person may not pass stools. The person may start developing an abdominal pain. So these are things we will train them to expect. And once they know what to expect, their acceptance regarding they won't be as alarmed as you in usual cases when they're unprepared about it. So training a caregiver, ma'am, has got a lot of elements to it, and very less you have to depend on how literate or educated the caregiver is. Because I'll tell you, in our home care settings, 90% of our patients whom we see are in home care settings. And out of those 90%, a vast majority of them, all of them are illiterates by socioeconomic standards or whatever. They're illiterates or not educated enough, but they manage well at home. And there will be certain red flags which we say that if there are certain red flags which you see, in that case, please contact us. There is a helpline number which we give, which is active 24/7. And if there is something which they are unable to handle, we send an ambulance to them if they can't afford and get the person to our care or to the nearest health facility. So this is the level of handholding which has to happen. It doesn't happen in one sitting. It happens in over multiple sittings. And I think in our communication sessions, we saw that, even if it's a bad news which you want to break, or if it is some diagnosis which they were not aware of, or treatment options they were not aware of, then these are things which after we understand them and we have to gauge, are they ready to listen to this right now at this point of time? Are they ready to listen to this and to receive this information? If yes, you go ahead. If no, then we take it slowly over multiple sessions. Did I answer your question, Dr. Nandini?
So we have to have a more descriptive session on caregivers. There has to be one topic specifically on caregivers.
We can look into it. It is not caregiver specific. That's what I'm trying to tell you. It is not caregiver specific.
Thank you.
It is condition specific, and how you can describe that, where the condition may lead to. What is the prognosis? So this is where
because
we need to...
if you say caregiver, in that anybody can come in.
Yes, absolutely. Absolutely, anybody can come. And it's not necessary a person has to know to read or write to understand what is being given. Many times we tell them by describing what is the color of the pill or what is the shape of the pill. Or many times we just write if they can read numbers. Most of these people can read numbers. So we just say that where it's 101 is written, that means you have to give it at night and morning and night. Like that, there are many ways you can do it. It is not always dependent on just what the person is able to read or not.
So I will tell what I understood by what you said is that the basic caregiver is you yourself, and you will have to train those people who are the caregivers, and you should be able to have those red flags, educate them with those red flags. Whenever those things rises, they come back to you, they'll call you up or they will help you. And we have to trust them that whatever you have taught them, that they will be able to implement it on ground.
Yes, sir.
That is one aspect of it, which I could get from what you said.
Absolutely.
Is there a way? I mean, I had heard somewhere the caregiver joins the patient while he is in the hospital, and the caregiver sees whatever is happening. So it becomes easy for them to follow the same protocols.
Yes.
In the
So exactly,
setup.
this is what we do over here. I think Dr. Sangeetha can elaborate on how is it that we actually get patients, and whenever we get them, we ask who is the person who is going to take care of this person at home. And we want that person to stay back. I think Dr. Sangeetha can elaborate on that.
Yeah, usually when a person is admitted here, we have a caregiver or the person. If your husband is admitted, definitely the wife will be the caregiver in usual scenario, or maybe whoever it is, even his mother or somebody like that, who is able to give care. And we teach them how things should be managed. When they get discharged from here also, we teach them these are the things you should be taking care of. Suppose if it's a bedridden patient, he's a paraplegic. So the care is definitely the important part that should be taught to the caregiver. How you take care of the skin, how the position change should be done, or how the catheter care should be given, or how the feeding should be done, or if he had recently had some stroke and he's on rice tube, and how you are going to feed, how you are going to do the rice tube feeding. All those things are being taught to the caregiver. Understood? So it is being, we give them the practice here, and then they go back home and they're confident enough to do it back at home. And what we do is we often, if it is in our home care area, definitely we go for review, and we go at home care and see how they are doing it at their home. So this is how we practice here.
So to be a little more specific, for the last 3 days, 3 to 4 or 3 to 5 days, depending on the situation, for the last 3 to 5 days before we intend a discharge, we will give complete handover to the caregiver, that A to Z, including wound management or shifting the person or giving the medication, everything A to Z is given to the caregiver. And we'll just be like observers. We'll just see what they're doing is it right or wrong, or will they be able to manage at home. And when we understand that they're able to do it or for 2 or 3 consecutive days, that's it. That's a green signal for us to decide that, okay, now they're ready to take care of things on their own and we can go ahead with the discharge. So that's how we practically do it over here on a day-to-day basis. I think further discussions we can take up after the case discussion. We have a case presentation as well. And a majority of it has already been covered now in the session. So I think it won't take long. Dr. Niyant, are you online?
Yes, sir.
Yes, please.
Am I audible?
Full screen? Yes, you are audible, sir.
Yes. Thank you, ma'am. It was a very informative lecture. So here I will be presenting a case. My name is Dr. Niyant Agrari. I'm working as a medical officer in PHC Kasansur. Next slide, please. So my case is of a 39-year-old female. Her diagnosis was dynamic small bowel obstruction. Next, please. So the patient presented with severe abdominal pain since 12 hours and vomiting since the same duration. Next. So history of illness. My patient had abdominal pain since 12 hours, which was generalized, sudden onset, non-radiating. There was no exacerbating or relieving factors and was intense when at peak. Vomiting was since around 12 hours and she had around 20 episodes from onset, which was not relieved by medications. There was no passage of stool or flatulence since 2 days. Patient had some abdominal surgery 15 years back. No details or record is available with the patient or with the family. Next. On examination, the patient was up febrile. Pulse rate was 110 by 110 beats per minute. Respiratory rate was 25 beats, 25 per minute. BP was 110 by 80 mm of Hg. Pallor was mildly present, and the patient was in severe pain at the time of examination. On abdominal examination, the upper abdomen was distended. Visible intestinal peristalsis was present. On auscultation, exaggerated bowel sounds were present. On percussion, the note was tympanic and the median scar of around 10 centimeter was visible. Next. Treatment and significant investigations. So here we administered injection pantoprazole 40 mg, IV, injection cefixime 400 mg, and injection metronidazole 400 mg. And significant investigation which we had done was complete blood count, liver function test, renal function test, C-reactive protein, and thyroid profile test. Next, please. Psychological aspects. Actually, the patient belonged to a tribal community and is married with 2 children. Patient was actually not willing to come for treatment, was brought by the family members. She had underwent some abdominal surgeries 15 years back in an NGO. The patient is not willing for allopathic treatment and was insisting on herbal treatment when she came. And actually, where the area which I am practicing, it is a tribal area. So here, this is now the time of harvesting, which is so for this, the hospitalization in this time means a loss of crop for the family for the whole year. So that was one of the psychological aspects. Medication same as which was given, because actually I am practicing in a primary health care center, so we just manage the initial phase and we refer them. So medication which I had given, I have just written. Next. Now, main concerns, the patient is from tribal background where health seeking is very poor. Also, the post-operative care in the form of wound care or any medication administration will also be an issue. Monetary problems as family was below poverty line and patient is not very willing to take allopathic medication. So the compliance is also poor. Summary, a 39-year-old female presented to PHC with complaint of pain in abdomen, vomiting, for which I referred her to district hospital and there she was diagnosed with obstruction and was operated upon. She was discharged 10 days post-operation and is now stable. Discussion point. First, how to communicate with the family regarding the situation. Second, how to convince the patient for taking treatment. Third, management of bowel obstruction in such cases. And fourth, how to improve her quality of life.
Thank you, doctor, for that brief presentation. So, so what are the challenges which came to your mind? Now we know that let's take it from where the patient is at this point. So the surgery is already done and the problem is already solved, right? Now,
Yes,
now
yes.
you are in the peripheral setup, and this person is coming back
Right.
to her village or to the area where she's living.
Yes.
What are the challenges which you expect from this person now, post-operatively?
Operatively, actually,
Not inside the
gave
hospital post-operative complications or anything. Now she's come back. There are certain things which you have highlighted
Yes.
in your presentation. So what were the
Yes.
challenges which you are expecting from this person?
So first of all, the first thing was regarding the compliance of the medication which have to be given. So first of all, administration will be very poor because she won't be able to understand herself because of the background. So we need to have someone like not educated but who will be able to understand, like as you explained, the danger signs and the basic facilities, the doses of the medicine. So that will be one issue. And second, if in case anything's red flag signs, so again the mobility will be an issue because she lives in very deep like area where there are no roads. So that is not generally an issue, but for me it is. And thirdly, now the post-operative care wound and all needs to be managed like very much specifically. So follow-up should be given, which I think they won't be doing, like the follow-up in 1 month, 2 months, 3 months, 6 months. So that will be also an issue.
All right, I agree. Did this person actually come back to you once they got back?
No, actually, I had visited her home because
Okay.
she came back to the home because the distance is very far from our PHC to the place where she lives. So she had went to district hospital and then she came directly home.
Okay, so you visited her, you did a home visit for
Yes.
her. What
Yes,
did
yes,
you
yes.
observe when you went there?
The patient had the dressing which I didn't open because she was not willing, and apart from that she was stable otherwise, like she was doing bed rest and otherwise she was stable. Pain and all she didn't complain much because she again thought if I will tell, because actually this is the whole story. So when I asked her, though pain and all she didn't tell me, but to her family members she was telling that she has some pain which is related on medications. So but she told me that she doesn't have anything, she is very okay now, because she thought otherwise I will again refer her or again advise her some treatments.
All right. So Dr. Manoj has brought out what I had in mind. Wound care. Dr. Nandini, I'll come back to you as a follow-up to what you had asked, the point which you had raised. Wound care is something now Dr. Niyant is concerned about in his setting. This is a tribal village person, not educated perhaps, and already he was reluctant to take proper treatment. But anyway, she at least has got the operation done and has come back home. Now you want to advise for home care, I mean for wound care to such a person. Dr. Nandini, what would you like to say to this person? You understand that this person doesn't understand anything about treatments or these kind of things at all, and no medical jargon also. And we have to make sure that whatever dressing she is going to do on a daily basis has to be as sterile as possible. So how are you going to advise this person?
No, but I don't know what is the IQ level of that person, whether the person will understand or not understand.
Okay, the person understands the same language as you speak. Let's start with that. What would you like to say to this person?
I can tell that you have to supposed to first hand wash. So I will teach all the steps of hand washing. For that, he has to have a good water supply, because most of the places in tribal area there is no water. So they use minimum water. Then for washing hands, you require soap. You cannot just wash hands by water, because I have seen there are people who wash hands only with water, but they don't know what is the concept of soap. There are places where there is no soap available. So you have to tell them that you have to, suppose to somebody who's coming from the sheher and coming from the city to the village. So you ask somebody to get a simple soap, and then you wash the hands with proper soap, and he has to wash hands till elbow. And I will teach all the steps of washing hands. So there is some proper protocol of washing hands. Then after that, depending upon the type of wound, first clean with normal saline, then clean with betadine. Then there is a ointment which is given specifically for that wound. So apply that ointment. There are some steps of, if you, then first I will ask him to wear the sterile gloves. So there is a proper technique of teaching of wearing the sterile gloves.
Okay, ma'am. Let's assume
And
that
once
we have
you,
not given sterile gloves to this person, and this person may not be able to follow putting on a sterile glove. Let's keep that aside. Please proceed.
but he has to do the dressing with sterile gloves only. He cannot do dressing without sterile gloves. He has
Okay.
to have a gloves, and then he has to do the dressing, because he have to maintain the aseptic and tell him not to touch anywhere. Then he has to apply the ointment and cover the wound. So there are some things like gamgee, then bandage. So accordingly, this is all my hypothetical assumption, but in reality, steps are something very different. So that way, I can teach him to do the wound management.
All right.
And the dressing has to be changed accordingly, like after 24 hours or after 2 days. And then
All right, ma'am. So what you have just explained, ma'am, this is the ideal way how we would like to do things, right? Now, when we are coming to a peripheral region, now we are going to be more realistic about what is locally available. Dr. Niyant, you are in a primary healthcare setup. One of the one of the things which we always say in primary healthcare is locally available, culturally acceptable. These are two things which always comes into picture. Now we have certain, realistically, there are gaps over here. Can we really do a complete sterile procedure at the home in a tribal village?
No.
It will probably be a kacha house.
Actually, in this case, luckily the village which she resides is the village of the sister, like the sub-center.
Right.
So sister there is active. So she had told that she will do the dressing like alternate day or one day, whatever it is. So that thing is possible if in cases where the village has a sub-center and the sister is really like into it. Otherwise, no, not at all. Because here in our place situation, it is not possible.
Yeah, so I'd just like to highlight few points over here, which may be a little bit of a tangent. This is where the importance of volunteers will come in. One thing is volunteers and identifying local resources who are there available within the village premises or within the locality. Idea of palliative care also is to make the community as self-sufficient as possible, as self-reliant as possible. Now you said that there is a nurse over there who lives in. Now this is a local resource which we can tap on, whom we can take help from, right? And I worked in Tamil Nadu and Karnataka in rural areas and in tribal villages, especially in Karnataka. And I've seen, Dr. Nandini, like the way you said exactly, water is scarce, soap may or may not be available, health-seeking behavior is very bad. These kind of situations do happen. And the only thing over there is education. That you tap one person in the village whom the village trusts, that who is somebody who is within the village. Once you get hold of that person and that person is convinced that this is important, that person makes sure that this becomes a snowballing of knowledge. That is, because the village members will accept that person as somebody who is within the community. he will listen to them. This is where the concept of ASHA workers also came in, right? ASHA workers are supposed to be, even if they are only 10 standard pass with certain basic degrees, certain basic training, they are somebody who are selected from within the community so that the community accepts what they have to say. Now, exactly like what you told, there is a nurse already over there. This is the person whom we need to get hold of, tell her the importance of this, and she will be the person who will take the ball forward. Another thing is, very true, this person may not be able to do a sterile dressing. Over here, what we are trying to do is, we'll try to do a clean dressing. That is, it is not sterile the way we would do it in a hospital setting or in a healthcare setting. But at the same time, we can take certain steps, even if it is using disposable gloves, but ensuring that we are not, the person is not physically touching the wound, or making sure that
Can I
after
go?
she
Actually, there's
cleans.
an emergency. So can I please leave? If
Sure,
it's
sure,
okay?
sure.
Okay, thank you. Thank you so much.
These are situations where we can train them. For example, how we train in our centers is, in our link centers is, we are, all these people will have a pressure cooker at home. Okay, everybody has a pressure cooker at home. We ask them to cut the gauze into smaller pieces, and then use the, whatever that plate is there to put the idli or to put the rice inside that. They stuff the gauze piece and then just steam it. This is a way of autoclaving in one way, right? So this is all locally available, culturally acceptable, simple innovations or small things which is being practiced on the field. So there are many things like this which we can advise them, which we look at. We can look at it later in the further coming sessions, depending on the situation and depending on the condition, what to advise. So this is what we do. We ask them to steam it in the pressure cooker, and once they have steamed and cooled it, after that, the surface which they intend to put on the wound, that should not be touched anywhere else, and that is put on the skin after the ointment. Or what we do is, we use metronidazole, which is powdered and sprinkled, or powdered and mixed along with Vaseline, and then put over the wound, and then the gauze is kept. So these are things which may not be acceptable in a hospital setting, or there may be better things to do in a hospital setting. But practically, these are things which we can do at their home, even if they have minimal resource with them. So there are things which we can explore, Dr. Nandini, and we will look at it. And I really wish for all of you to someday make time to come to our setting so that we can demonstrate all this as well. Because there are many things which may be alarming, which is seen from a perspective of a hospital practitioner. But on the field, it's a different ball game, and it works miraculously many a times. We have seen people with non-healing ulcers for many months or years, and we just train them in a few things to, ensure. And then it takes a couple of months, it takes some time, but it gets healed. There are n number of cases like that which we can demonstrate, which we can show you. So I think we have overshot by 5 minutes. For now, I think that's all. Dr. Sangeetha, any closing remarks from your end?
Okay. So we started with intestinal obstruction, and discussion went on with wound care and everything. But anyways, coming back to intestinal obstruction, it is, as I said in the beginning of my session, it is one among the most mismanaged symptom. And after this session, I hope at least something was beneficial. And in your day-to-day practice, try implementing all those things. And definitely there will be a lot of doubts regarding this, because once you see and practice, only then you will know how to deal with such kind of patients. So feel free to contact us if something or some situation happens similar to this. And we are always there to help you. And it is a mutual learning. Definitely, we all will learn together. And feel free to use this platform. And also, as Dr. Deepak said, feel free to come to Pallium and see what is happening here. And hope this session was really useful for everyone. Thank you.
Thank you, Dr. Sangeetha. Shripriya, over to you.
Thank you, Dr. Deepak. Thank you, Dr. Sangeetha, because I personally know that both of you have had a very tiring day with home visits and medical college visits and all, and still I can see that with the dim lighting, your faces are still bright. Thank you. Thank you for finding out time for this cohort. And thank you everyone for joining in, and hope that this session was also informative as you all expected. So with the promise that we will meet again with another interesting topic and an experienced faculty. This is Sri Priya, along with Dr. Sangeetha and Dr. Deepak Sudhakaran, signing off from the Tips Eco Hub. See you till then, everyone. Take care. Bye-bye.
Thank you, Shri Priya. Have a good evening, everyone.